This is Dr. Catlin. This is a recording of the lecture for the module 16F, heart failure. Starts on page 1228 in your Pearson text. Heart failure is when the heart is unable to pump enough blood into circulation to meet the body's needs. Occurs when the heart muscle is damaged or stressed, often caused by a combination of ineffective contraction and relaxation, a result of the heart's inability to meet the body's demands. Cardiac output falls, leading to decreased tissue perfusion. It's a progressive condition developing over time as the heart muscle becomes weaker. Pulmonary edema is a common consequence, and we will talk about pulmonary edema in this lecture. Abnormal accumulation of fluid in the interstitial tissue and alveoli of the lungs. That is what pulmonary edema is. This is just a drawing somebody did on talking about heart failure and, coming from the body into the right side to the lungs, getting the oxygen coming to the left side, and a failure on either side. Cause of heart failure can be impaired myocardial function. It can be increased cardiac workload or non-cardiac acute conditions. Compensatory mechanisms, we have to talk about Starling's law, which is the greater the stretch of the cardiac muscle fibers, the greater the force of the contraction. You think of anything when you do a sling, the further back you bring it, the further the force is when it goes. So the muscle has to be able to stretch out well in those fibers to force a better contraction. The stroke volume of the heart increases in response to the increased volume of blood in the ventricles. So as the ventricle stretches with the fluid, before the contraction, the stroke volume is increased. Stroke volume is the volume of blood ejected each heartbeat. So your stroke volume, the volume of blood ejected with each heartbeat, times your heart rate equals your cardiac output. So your stroke volume, the amount of blood injected, is the difference between your end diastolic and end systolic volumes. The ejection is normally about 2/3 of the blood that is in your ventricle. Your cardiac output is determined by your preload, afterload, and myocardial contractility. How much blood, how much pressure is on either side, the blood filling, and the force going out. Ejection fraction is a measurement expressed as a percentage of how much blood the left ventricle pumps in each contraction. An ejection fraction is 60%, means 60% of the total volume of the left ventricle is pushed out. A normal ejection fraction is 50 to 70%. Increased myocardial oxygen demand is limited by Heart failure leads to increased myocardial oxygen demand and can limit cardiac output or ejection fraction due to overstretching. Oh, didn't change. Hit the wrong button. Okay, some more compensatory mechanisms. The decrease in cardiac output stimulates the sympathetic nervous system and releases catecholamines. The AMP and your BMP, your natriuretic peptides, could not get that out, are vasodilators. They inhibit the renin-angiotensin-aldosterone system and the sympathetic nervous system to suppress the progression of heart failure. So this AMP and BMP are released in response to the heart failure trying to suppress the progression. It's when, if you've listened to the cardiomyopathy, BMP can now be produced, and they try to use it to help with the heart failure. And here we will learn that BMP is a measurement they use in monitoring heart failure. The infusion of a synthetic AMP or BMP is effective in treatment of acute heart failure because it tries to suppress the progression and stop that renin-angiotensin-aldosterone system, the RAAS, and stop stimulation of the sympathetic nervous system, because the sympathetic nervous system leads to increased catecholamines, increased workload of the heart. Hopefully that makes sense. Complications from this compensatory mechanism is actually increased heart work, renal vasoconstriction, decreased renal perfusion, increased pre- and afterload, leading to pulmonary congestion and more fluid retention. As it's not perfusing well, you have anaerobic metabolism and lactic acidosis. Also, you have a tachycardia and a decreased filling time, because if the heart's going faster, less time for the ventricle to fill, which worsens the symptoms. So the heart's attempt to help itself actually can worsen it. Ventricular hypertrophy. Hypertrophy starts as a compensatory. It starts to thicken the muscle to try to increase the force, but that leads to a worsening heart failure and decompensation and an enlargement or dilatation of that ventricle. There's systolic and diastolic dysfunction. Systole occurs when the systolic dysfunction occurs when the ventricle fails to adequately contract. So remember, systole, if you think of your blood pressure, systole is your high number when the blood is pumping out of the heart. So end of systole is the end of the ventricular contraction. So systolic dysfunction is when that ventricle fails to adequately contract. This function is affected by the loss of myocardial cells, especially like a left ventricular MI. Systolic etiologies: ischemic heart disease, chronic hypertension, dilated cardiomyopathies, and myocarditis. The left ventricular wall, or the ventricular wall on either side, is thin and weak heart muscles, so they have a low ejection fraction. Diastolic, over here, diastolic dysfunction. Remember, diastole is occurring when the atrium squeezes to fill up the ventricles. So end diastolic pressure, end diastolic volume is after the atrial contracts. So diastolic failure occurs when the heart cannot completely relax, results from a decreased in ventricular compliance. So the atrium is trying to squeeze into the ventricle, but the ventricle is stiff and won't let it fill. So it's a stiff, thick heart muscle, impairs the filling and relaxation. Causes of diastolic dysfunction or hypertension with left ventricular hypertrophy. That left ventricle has been pumping against that extreme aortic pressures because of the vascular resistance. Restrictive and hypertrophic cardiomyopathy, which is discussed in that chapter. Fibrosis, amyloidosis, sarcoidosis, these are connective tissue diseases. Constrictive pericarditis, hemochromatosis, which I talk about in the cardiomyopathies, that's the elevated iron stores, valvular diseases, and aging. This is just two diagrams showing right-sided versus left-sided heart failure. Remember, the right-sided failure, everything is backing up systemically. Both have fatigue, but with your right-sided failure, it backs up into the body, so you increase peripheral venous pressure, increased peripheral edema, enlarged liver and spleen, fatigue, may be secondary to chronic pulmonary problems, because the COPD, or because pulmonary pressures backing up into the right, distended jugular veins, all the GI symptoms with anorexia, GI distress, weight gain, dependent edema. Left-sided failure. The blood is having trouble pumping out of the left side of the heart to the body, so they are fatigued, but it is backing up into the lungs, so they're restless. They have decreased perfusion to the heart and to the whole body, so they're confused, orthopnic, tachycardic, because the body's trying to compensate, exertional dyspnea, cyanosis, elevated pulmonary capillary wedge pressure. I will talk about, well, I might as well mention it now. I will mention again about a Swan-Ganz catheter. It goes in and into the right atrium, subclavian. They go into the right atrium, right ventricle, and it puts itself into the pulmonary artery to measure those pressures. And then when you do a balloon and put a wedge in there, you get a reading that gives you an idea of the pressures on the left side of the heart. So that elevated pulmonary capillary wedge pressure is showing you there's increased pressures on the left side of the heart, which would be because of left-sided heart failure. You'll have paroxysmal nocturnal dyspnea, crackles, wheezes, possibly blood-tinged sputum, especially if they are developing pulmonary edema, because the pressures in the lungs get so significant, they're pushing into the arterioles and bursting those, and tachypnea. Risk factors: coronary artery disease, smoking, lung disease, obesity, substance abuse, hypertension, diabetes, black population more so than the white, and increases with age. As you listen to each of these lectures, hopefully each one will give you information helping with the other topics. Diagnostic tests, I have not seen the AMP tested for. I have seen the BNP tested for. Your monitoring electrolytes, urinalysis, kidney function through your BUN and creatinine, liver function. Remember, we're looking at right and or left-sided failure. Thyroid function, because we're looking for metabolic causes. Monitoring your gas exchange, your chest x-ray for heart failure and size of your heart and your lungs. Echocardiogram, looking at all the valves, looking at the pump, looking at the flow, the tissue thickness. Doppler flow studies, looking for that blood flow too. Causes of pulmonary edema. Pulmonary edema can be caused by congestive heart failure. Congestive heart failure can be a heart attack, cardiomyopathy, aortic valve disease, significant high blood pressure, and a right to left shunt. All can lead to congestive heart failure, and those left-sided congestive heart failure can lead to pulmonary edema. Pulmonary edema can also be related to a non-cardiogenic or non-cardiac cause, such as high-altitude exposure, kidney failure, obstruction of arteries to the kidneys, that kidney arterial stenosis, lung damage through gases or infection, major lung injury, and certain medications. Pulmonary edema develops within hours after exposure to a drug or a medication, gas. It can resolve when that drug or exposure is pulled away. Common drugs that can lead to pulmonary edema are sympathomimetics. They stimulate the sympathetic nervous system. Dopamine, dobutamine, clonidine, norepi and epi, certain narcotics, carbamazepine, which is Tegretol, hydrochlorothiazide, which is a diuretic, certain IV contrast agents used in x-rays, methotrexate, protamine. Here, when it right to left shunt is your PDA that you should have learned about in your pediatrics. Which is your patent ductus arteriosus. It causes a shunt from left to right, that is that hole or that defect and the blood is oxygenated blood is shunting back over to the right side, and it can lead to heart failure and pulmonary hypertension, which would then again worsen the heart failure. Okay, keep going. Picture pulmonary edema. Left ventricle cannot handle the overload of the blood volume. The pressure increases in the pulmonary vasculature. The fluid starts to move out of the pulmonary capillaries into the interstitial tissue of the lungs. Let's see. This fluid reduces the normal oxygen movement through the lungs. They get interstitial edema and shortness of breath. Clinical manifestations of pulmonary edema. So you can distinguish this from the congestive heart failure. Some of them are in both. Coughing and restlessness during sleep is the main symptom of pulmonary edema. It's a sudden onset of dyspnea where heart failure usually builds up over time. Severe anxiety, restlessness, irritability, a feeling of doom, cool, moist skin, tachycardia, orthopnea, distended neck, distended jugular veins, noisy, wet respirations that don't clear with coughing is a big sign. Cough with frothy blood-tinged sputum and that feeling of doom, anxiety, cyanosis, paroxysmal nocturnal dyspnea. This is happening because of the pressures in the lungs are forcing busting vessels in the arterioles in the lungs. Oh, my brain's tired. Hemodynamic monitoring, Swan-Ganz catheter. This is a picture, of course, not within the body. From this point out, these are all outside. Otherwise, it threads in. It literally goes in the right, through the subclavian. They go into the right atrium, right ventricle, and it sits in the pulmonary artery. So you get pressures of the right atrium, right ventricle, pulmonary artery, and you can put a wedge in there with a balloon, stop the flow for a second, which is what you see here. Normal is 8 to 12. It's giving you an idea of the reflection of the pressures on the left side of the heart. So your wedge pressure should be 8 to 12. These are your pulmonary artery pressures, which comes 15 to 25 over 8 to 10. Usually you go with your mean, which is 10 to 20. So remember your wedge pressure, 8 to 12, pulmonary artery pressures, 10 to 12. Your right atrial pressure, which is, oh, why it says 0 to 6. I don't know why that says 0 to 6. I always think of your right atrial pressure as being your central venous pressure. CVP should be 5 to 10. Remember how to get your mean arterial pressure, it's 2 times your diastolic plus your systolic divided by 3. It's also your cardiac output times your systemic vascular resistance, which is a whole huge calculation you'll do if you go into critical care. Potential complications of doing hemodynamic monitoring with the Swan-Ganz catheter are bleeding hematoma, pneumothorax, hemothorax, arterial puncture, dysrhythmias, venospasm, infection, air embolism, thromboembolism, nerve injury of brachial or thoracic, depending on which way they go in. And I have not seen them go in brachial, but I'm sure they can. But with all those complications, you see why the Swan-Ganz catheter is not used as much as it used to, even though it gives you valuable information. You're literally passing this catheter through. You can cause infection, air emboli, you can damage vessel, you can puncture vessel, you can, if they have a very enlarged right ventricle, which I saw once, and it kept looping in the right ventricle, trying to get in the pulmonary artery, and eventually actually ruptured the ventricular wall, and that person died. You can have, I don't have pictures here of your A-line or arterial line. It's like an IV catheter, but it sits in the artery and stays there. You can draw your blood gases from it, and you have a continuous monitoring of your actual intra-arterial pressure or blood pressures. One treatment is cardiac resynchronization therapy, used to treat the delay in heart ventricular contractions when the heart failure is really advanced. So they do a biventricular pacing. They're pacing both ventricles to try to get them in union and increase increase where the atrium squeeze, the ventricle squeeze, to try to get the impulses where they go in synchrony and improve output. Yeah. It's pharmacology for congestive heart failure. There is a video on Moodle. I'm going to upload it. I'm going to upload it also to your team, so you'll have it in both places. It talks about your preload and afterload. Preload and afterload are managed with your ACE inhibitors and your ARBs. Your preload is the volume of blood in the ventricle at the end of diastole, your end diastolic pressure. So, because the end of diastole is when the ventricles have filled. So the volume there is your preload. How much is in that ventricle when it's getting ready to squeeze? Preload. Afterload is how much pressure that ventricle has to pump against to empty itself out. And resistance left ventricle must overcome to circulate the blood. And your afterload is your cardiac workload. ACE inhibitors, if you remember, they relax the blood vasculature, they decrease your oxygen demand of the heart. Let's see. ACE inhibitors and ARBs both have your first dose, what's called the first dose effect, which you might have hypotension with the very first dose, significant hypotension. What else? ACE inhibitors are not the primary, or not to be used alone in the African American population. It's used in combination usually with a diuretic. Oh, I didn't realize I do have another slide here where I talk about your ACE inhibitors. It's your PRILs, decrease peripheral vascular resistance, which decreases your afterload. Said about the first dose, report the cough because of the way it works, and there's an enzyme that gets released in the lungs in the ACE inhibitors, but not in the ARBs. Both ACE inhibitors and ARBs watch for angioedema, renal damage, hyperkalemia. Be cautious if they have elevated potassium, or giving them with a potassium-sparing diuretics such as spironolactone. Do not give an ACE inhibitor or ARB if they have renal artery stenosis that has not been repaired. Monitor for blood dyscrasias. With ACE inhibitors, you're looking for neutropenia. Your ARBs work very closely the same way, but it's in the same purpose. Increasing preload, decreasing your afterload, relaxing that vasculature to decrease that oxygen demand. It doesn't cause the cough, angioedema, renal failure, fetal harm. Both ACEs and ARBs are contraindicated in pregnancy. Okay. Your beta blockers. Typically not used during an acute exacerbation. Again, you don't want to relax that heart muscle too much. You want it to be able to work. But if they're already on it, you're going to continue. You never do an abrupt cessation of beta blockers, because that can have this rebound. May need to decrease the dose if they have a symptomatic hypotension with it. The beta blockers inhibit the sympathetic nervous system activity. They can be given in very low doses with heart failure, and combined with ACE inhibitors. If somebody is not on a beta blocker already, when they do it for heart failure, carvedilol is the beta blocker that is preferred. That's why I have carvedilol on here, and it's low dose. That's the one they like to use if they're not already on a beta blocker and they develop heart failure. Contraindicated in asthma and COPD because it can cause some bronchospasms. Caution in renal impairment, peripheral vascular disease, in caution in diabetes because it can mask hypoglycemia effects. It can impact the thyroid levels in a thyroid disease, can lead to dizziness, drowsiness, contraindicated in second and third degree heart blocks. I think that's about it for your beta blockers. Your calcium channel blockers. Treat hypertension, prophylactic for angina, prevent or control SVT. They improve the cardiac function by inhibiting the sympathetic nervous system activity. They're given in very low doses, just like the beta blocker, often in combination with an ACE inhibitor. Relaxes the arterial smooth muscle, decreasing the heart rate, decreases the coronary vascular resistance, which increases the coronary blood flow, so that decreases the heart's demand or myocardial muscle for demand for oxygen by decreasing the contractility, promotes dilation of the arterioles and helps with regulate the peripheral vascular resistance. It can cause a reflex tachycardia and possible orthostatic hypotension. Calcium channel blockers are more effective in the African American population. You want to watch them for bradycardia, drop in blood pressure, headache, constipation, nausea, peripheral edema, which is a common adverse effect. Avoid, if they're on a calcium channel blocker, avoid giving with grapefruit juice and garlic, because both of those can increase the effects of the calcium channel blocker. And St. John's wort decreases the effectiveness of a calcium channel blocker. Vasodilator, hydralazine is used in heart failure to decrease. If heart failure has a reduced ejection fraction, they will treat it with hydralazine or nitroprusside vasodilators because they relax the smooth muscle in the blood vessels, causing dilation. It reduces the peripheral vascular resistance, which reduces your afterload. That's a resistance it pumps against, so the heart doesn't have to work as hard. It also reduces your systemic vascular resistance. There can be a reflex tachycardia, just like in your calcium channel blocker. Caution if somebody has angina with coronary artery disease, renal impairment, and a history of a CVA. Monitor for sodium and water retention. Monitor their blood pressure and heart rate, EKG rhythm. It's preferred if they're getting hydralazine. Nitroprusside is only given IV. If your hydralazine is given IV, they need to be on continuous cardiac monitoring. Watch for rebound hypertension. They have to be taken off it slowly, just like with your beta blocker, because they can be a rebound. Adverse effects are headache, flushing, and tachycardia. Direct vasodilation with nitroprusside or nitroglycerin. I've talked about nitroglycerin before. It's not as effective as a direct vasodilator in a heart failure, so they may use nitroprusside. Nitroprusside is not used as much as it used to be. It's also sensitive. Both nitroprusside and nitroglycerin are sensitive to light. The cyanide toxicity, if they're on it more than 48 hours, and I said it's not used as often as it used to be, but both of these will vasodilate arteries and veins. Nitroprusside is used more in a cardiogenic shock leading to heart failure. Monitor for confusion and dizziness. Closely monitor the blood pressure because it will drop it. As I said, you have to protect it from light. Digoxin we've talked about before. Assess their heart rate. Hold if the heart rate is less than 60. Assess for bradycardia, dig toxicity, anorexia, nausea, vomiting, diarrhea, halo yellow around their visual, dysrhythmias. Males might get gynecomastia and impotence. Use it with caution with a symptomatic heart failure. It has a positive inotrope, which helps with that squeeze, but has a very narrow therapeutic index. The level is toxic if it's greater than 2. Digibond is what usually now you treat it as acute toxicity. If somebody overdosed on digoxin, you would give them charcoal, but otherwise it's a Digibond. Your loop diuretics, we've talked about loop diuretics. Here's some mnemonics that might help you. It is used in heart failure. Watch for hyponatremia, hypokalemia, hypomagnesemia, ototoxicity. May lead to diarrhea or constipation and abdominal cramps. All diuretics, no matter which kind, watch for dehydration and hypotension. Thiazide diuretics and loop diuretics have a risk of elevating the cholesterol levels and triglycerides. Thiazide diuretics, hydrochlorothiazide is the one that I tend to talk about the most. Same uses and precautions as in your loop diuretics. Also have to watch your uric acid level because it can cause uricemia or elevation in uric acid, hyperuricemia. Pancreatitis, watch for rash, may lead to photosensitivity. Watch your potassium. It's not as potent as in your loop diuretics, but it can lower your potassium levels, chloride levels. It can lead to an increase in glucose levels, also in your triglycerides and cholesterol. But mostly watch your glucose levels. Use caution in hydrochlorothiazide or thiazide diuretic in a diabetic. Potassium-sparing diuretic, spironolactone or aldactone. It blocks the aldosterone, is why it is used in your heart failure. Watch uric acid levels. Monitor your CBC for blood dyscrasias. It can lead to males with gynecomastia, testicular hypertrophy, hirsutism, that extra hair growth, which is usually with prolonged use. Hyponatremia, rash, abdominal pain, hyperkalemia because it's potassium sparing, and nausea or adverse effects to watch for. Sympathomimetics are vasoconstrictors and inotropes. I talked about inotropes in the cardiomyopathy lecture. Inotropes to help with that squeeze, dopamine, dobutamine, isoprel. You'll see these drugs, especially isoprel, much more, norepi and epi, also when we start talking about shock after this next test. Vasoconstrictors and inotropes, those sympathomimetics, they mimic the sympathetic nervous system, so the fight or flight. They cause a vasoconstriction, which increases the blood pressure. They stimulate the beta adrenergic receptors so that the heart squeezes stronger, improve the perfusion with the heart rate and the cardiac output. But unfortunately, these increase the oxygen demand of the myocardium. And here, epi is not used so much in heart failure as it is more for anaphylaxis and in shocks. So you might see a norepi, mostly you're going to see dopamine and dobutamine, possibly Isoprel. Watch for anxiety, vascular constriction, watch your urine output. Antiarrhythmics, I'm not going to cover again because that's been covered for this material for this unit. This is just some calculations on doing mics per kilo and mics per minute calculations, because most of these drugs will be in one of those formats. Some other terms to be familiar with: cardiac tamponade. Think of stampeding, tampering something. Cardiac tampon, it's a compression of the heart. Decompensation is a failure of the compensatory mechanism to restore tissue perfusion. The body starts to compensate and then it gets exhausted and decompensates. Nocturia is voiding 2 or more times at night. Orthopnea is difficulty breathing when laying flat. Paroxysmal nocturnal dyspnea, waking at night, acutely short of breath. Your physical exam. Your assessment includes a whole physical exam, vital signs, appearance, skin mucous membranes, neck vein distension, auscultating heart, lungs, bowel sounds. You're looking for right and left-sided heart failure symptoms and signs of decreased perfusion. Observe for shortness of breath, activity intolerance, weight gain, cough, ease of breathing with talking. Remember, 1 kilogram, which is 2.2 pounds, equals 1 liter of fluid. Edema is not a good assessment tool in heart failure. You're going to go more with your weight and your output. Nursing diagnosis: decreased cardiac output, excess fluid volume, activity intolerance, deficient knowledge. You want to encourage rest, monitor vitals and O2 sat, monitor your BNP levels, auscultate heart and breath sounds. Remember, BNP goes up with heart failure. Some people that are in chronic heart failure have just say sustain elevated BNP levels, but in acute state, they're a marker for heart failure. Auscultate your heart and breath sounds. You're looking for S3, S4 gallops. You're looking for crackles in the lungs. Administer supplemental oxygen. Administer the medications to help with your cardiac output. Monitor for your respiratory status, INO, abdominal girth, hemodynamic parameters, and restrict your fluids. Rest periods with activities. Assist with ADLs, activities, educate on activities once the discharge, and teach them about progressive activities as tolerated. And that is the end of this lecture.